Hi everybody, welcome. My name's Jim and I am in the Rehabilitation Services Department. I'm a physical therapist, been with ACMC about 18 years, went to school in Buffalo, New York, from PT school. We have sites, if you walk 2 blocks this way to the south, is our outpatient site. We also do inpatient PT and skilled nursing PT in the hospital on the 3rd floor. And we have a facility in Jefferson, Family Health Center in Jefferson, where we provide PT, and a facility in Conneaut. So it's a growing service line, and we like to work with folks who are either dealing with injuries or trying to prevent future injuries. So talking today, kind of going a little bit specific. Who was here last year at the talk I gave? I'm sure some of you. Okay. So I'll try not to be repetitive to that, but I'm going to elaborate on some of the themes that we talked about last year. I tend to go technical, so if I've looked for a few people to just give me the move on kind of signal if I get too deep, too technical. But I'll take questions at the end if you have them. Certainly if you have any questions or clarifications on the slides, let me know. All right, so why talk about back pain? Obviously, it's very common. A lot of it, if you give back pain enough time, it'll heal up on its own. So not every back pain situation needs an MRI. Not every back pain situation needs an X-ray. A lot of times, give them 6-8 weeks and they solve out on their own. But the idea here, what I want to do today is, there we go, kind of teach you a little bit about why is that going to show up there. Oh gosh, go back for me. Can you go back on the slide? Left arrow. Yes. Okay. All right. So teach you a little bit about recognizing early warning signs, like what to do, what not to do. I'm going to kind of focus a little bit more on the disc. Problems with the disc. There's a plethora of different things that can go wrong in the back, but disc is one of the main features, and one of the things, if they're healthy, your back is in good shape, and if they're not healthy, it can lead to a cascade of other problems too. So 7 neck vertebrae, 12 thoracic vertebrae. The thoracic vertebrae, think of those as where your ribs connect, so those are the middle section. You'll notice the inward curve at the cervical spine, the opposite direction curve at the thoracic, and then another inward curve down in the lumbar. So there's 5 lumbar vertebrae. And out of each one, if we can get that there. This is my pointer today, so no laser. But these little exit spots are where your nerves come out of the spine. And nerves like space. They don't like to be encroached. So if you have good space there, life is normally pretty good. So if we go a little bit deeper, kind of a closer look to see what we're talking about, spinal cord typically ends in the upper part of the lumbar spine, and then you'll see all the nerve roots exiting. This would be a top-down view, so you'd see the disc. You'll see a lot of circular rings around here. We'll talk a little bit more about that. And that's the nucleus. So if you'll remember science from 7th, 8th grade, the nucleus is the cells, kind of the center. So back here is your spinal cord, and these are the nerve roots that are exiting your spinal cord. And these kind of run down your legs or your arms, and they give you a sensation and motor function of the extremities. Just a little more functional anatomy, and then we'll move on. The reason I like to highlight this is the core is multi-layered. And if you saw my talk last year, I think it was last year, we talked about where the body forms, kind of the design is crossing fibers, create more strength. So you'll see that you've got the outer layer, the rectus femoris, running vertically. The external obliques running kind of obliquely. So they get their name. And then you've got the transverse abdominis running horizontally, and the internal obliques running the opposite direction. So you've got a series of crosses which create extra strength. We all have them. Some of them are just deeper in there than others. So, this would be, so that was the front side, this is the back side. So again, I like to look at the spine. It's kind of like a crane, and the muscles are the hydraulics, so they're providing the power to it. And if the crane is rigid, life's good. If the crane is bendy when you're doing these movements, then you run into trouble. So these are dermatomes, and really all this is saying is these are the sensory layers of intervention or innervation. So basically, just again using, and I talked about this last year, pain as a language. If you're having pain or problems in certain areas, it's really telling us information. So if you're having pain along a certain area of the outside of your leg, if you're anatomically like the norm, we can kind of track that back up to a certain level of the spine. So it's valuable information. It might not be on the front end, but if that pain is radiating down, that can tell us typically where your issue is and what sorts of interventions we can do. Same thing, instead of the sensation, we also have myotones. And really what these are is the level that corresponds to different muscle function. So if you have a weakness in the ability to raise up on your calf, we know that that points to really your bottom vertebrae. If we believe it's a spine problem and you have no strength there, then we know, okay, let's backtrack and look for an issue there. Same thing up in the neck, same things. And the other reason, we might test reflexes, physician might test reflexes. Again, those track back to central parts of certain areas of the spine. So if you come to a therapist, or if you come to a therapist who's McKenzie-based, this is the typical sorts of evaluation sequence that we're going to walk you through. A lot of questions, a lot of history, because we want to understand the mechanics of your situation. And you'll be telling us information you might not even know it. So as we're talking to you, taking your history, we're looking at your postural habit. Are you upright? Are you slouched? Do you kind of scooch sideways? Are you looking for areas to escape pain? A lot of times when people are in acute disc pain, they're moving all over the place because they can't stay sitting for more than a few minutes. We look for a mechanism of injury. A lot of times it's not there. Can't point to one specific event. It just developed insidiously. Sometimes there is a specific mechanism. Other times there's not. We kind of take a laundry list of better, worse. What movements help you? What movements hurt you? And then we try to identify commonalities in the pattern. Usually there's a pretty clear pattern. It just takes that assembly. One of the key features is pain location and pain behavior. Peripheralizing or centralizing. Really, there's another slide that's going to show this a little bit, but if you think about peripheralizing pain, it's pain starting in the middle and then peripheralizing down your leg. It's normally a bad sign, and it almost always points to the disc as the problem. There's a few other things that can cause it, but usually it's a disc issue. And centralizing would be the exact opposite. So taking it, if you have leg pain and you're doing a movement and it gets out of the leg, it's a very strong positive indicator. You're doing the right thing. If you're doing something that's peripheralizing your pain, 9 chances out of 10, we're going to tell you to stop doing that movement. We're going to assess your baseline motion. A lot of times when you have a disc protrusion or bulge, and we'll go over the differences there, you're going to have a movement that you're obstructed, you can't do, or it's very painful to do. And the example I can give you there is, if you've never had it, that's fantastic. You're probably in the minority. But if you sat down for a very long time frame in a slumped position, maybe changing a tire, for me it's like trimming my dog. I'm trying to stay here and fight with her for about an hour, and I get up and I'm like, oh, I cannot stand. You have this 3 minutes, 4 minutes, 5 minutes, and then finally you can stand up, walk around, move around. What typically happened there is very likely disc material accumulated backward. If you think about a disc like a jelly donut, if you bend forward, jelly migrated backward over time. It's that nucleus stuff, and then all of a sudden it became difficult and obstructed to stand back up. Fortunately, I didn't spend another 2 hours there and probably give myself a permanent injury. I got up, changed position. We're also looking for red flags, anything that really wouldn't add up, something that wouldn't look like a spine problem. If we can't affect the pain with movement, if there's signs of systemic disease, something that needs to get back addressed in the physician's office. Look for neurological signs of strength, numbness, all that stuff, and we look for directional preference. So we try to send the patient home doing a movement that is helpful, that's going to solve the pain or reduce the pain. So again, you're talking the disc, this would be the nuclear material migrating out. And the reason we're so concerned about these is because they are right next door to the spinal cord, and we know if that protrusion is large enough into the spinal cord, you can start to create paralysis type symptoms or symptoms bordering into that. Fortunately, there's a very strong ligament back there that supports that and prevents that, but some of the questions we may ask is, are you having bowel or bladder change? Anything where you've lost strength, lost reflex, those sorts of things. And those are usually signs that need to be evaluated by specialists. A little bit deeper look at the anatomy. So it's the same thing, like we talked about with the crossing of the muscles. The disc is made up of a series of radial, almost like a radial tire crossing pattern, very strong. This would be kind of that cross section if we've taken half the spine. This would be the person's front, This would be their back over here. But you'll see these crossing pattern fibers are very thick, and this blue would represent the nuclear material. You'll see in the front it's a little thicker, so we know that ring around the edge is called the annulus, and it's a little thinner back here. So we're more susceptible usually to that stuff moving backward, or migrating backward, because these rings, as we age, can get a little bit degenerative, so that nuclear material can get back in there a little bit easier if we do the wrong movement. The disc is pretty awesome. It's very powerful. You can take a lot of compressive force and not do any harm to it. We could stand, we could stay vertical. The force gets distributed evenly throughout the whole disc. This is how we're supposed to load the disc, but we don't tend to. Why did that happen? We don't tend to always load it like that. We tend to do this kind of stuff, and that's where problems develop. You load it asymmetrically, you bend over, pick up a pencil one way, you flex forward, and all of a sudden you've got a bias of heavy force on one side of the disc and very light force on the other, and that creates a pinching problem. So that would be kind of an asymmetric. Torsion load would be rotational, so the last one there. And the annulus, based on all the fibers going different, we're pretty good at absorbing torsional loads, but if you combine a torsion with a twist or flex, that's when the wheels fall off. Gosh, I keep doing that. All right, so this is that centralizing, peripheralizing slide. Really the main takeaway, almost always good, centralizing. So if you start here, and by the end of the treatment session, you're more like this guy here, you've done very well, and if you continue that pathway, you're probably going to solve the problem quicker. If you've done this, you started with pain in the center of the back all the way down on that end, and you worked your way this way, unless there's a very specific reason, there's one or two specific reasons where you'd want to do that, you've probably made yourself worse. The only way you would want to do that is if you have a scar tissue around a nerve root that you're trying to stretch out. What's that? You got a pointer, good. Then I'll stop making these crazy things come up. Okay, so we use this all the time. Very good indicator if we can get centralization. At your first session, if we can get this, we're doing almost a victory dance. All right, so a lot of times folks will complain of pain in their hip or their butt, and they'll say, it's not my back, it's my hip, or it's my muscle in my leg, it's radiating down. They may not even have any back pain. And the reason really for this, let's try out our little, yes, okay, is the location of the main nerve trunk kind of exits right there. So if you ever felt that burning, searing pain right in your butt, chances are there's nothing wrong there. It's upstream. It's up in your spine. There's a pinching up there. There are a few conditions that can create symptoms here. One's piriform syndrome, tightness of the muscle around there. But these are generally problems that are going to go away within a few days. If your problem's lingering or if you're getting radiating symptoms, then you got to hunt upstream usually. All right, so why do these things happen? Kind of like what I was talking about before. We normally don't load the disc always vertically. We load it in bad positions. So a lot of times folks will do an activity and then they'll come home and rest and they'll sit like this for 2 hours and then they'll say, gosh, it must have been tennis I did this afternoon. Well, probably not. The tennis loosened everything up. What Moses just had you guys do over there loosened everything up, and then you relaxed and you slumped. And what ended up happening is the disc material migrated backward and all of a sudden started touching the nerve root. We showed this slide last year and a lot of folks gave good feedback, so I figured I'd throw it in. This is just the effect of loading just by posture alone. There's a few more slides that will show that kind of demonstrate this. We didn't change the weight of your head, but by changing the angle away from midline, the effective pressure on your spine is up by a factor of 3 or 4. So what feels like 10, 12 pounds on your spine here, if your head's out there, it feels like a lot more, so that the spine has to absorb a lot more pressure. Same thing with the crane. Like I said, that's how the cranes are designed. They're not designed like that. We do that all the time. So it's basically we're giving our knees a holiday here, and we're saying, I could do this, it's easy enough. So if we kind of practice that pattern a little bit more, a lot of us would be in lesser amount of back pain. Another good slide, this came out of a study, this was back in the 90s, but they've done a few studies that kind of reinforce it. Again, we're talking about disc load and kind of vertical. So this is the position of your body, and that's the effective pressure. So 100% effective pressure would be kind of just standing vertically. So you can see lying down takes pressure off. So one of the mainstays when someone's dealing with the disc issues, we're going to tell them, get unloaded frequently. Lie down. Get off your duff, really. Stand and walk if you cannot lie down, because as soon as you start to do other stuff, that's increasing disc pressure. So you can see, bending forward, picking up a little bit of something off the floor, you're 275% of disc pressure. And the way they did this, they stuck little needles, I don't know who it was because they were brave, but they stuck needles in folks and assessed real-time pressures. I think some of them they did cadaveric, but I think they've since gone and done living people. So brave folks, but good body mechanics, good posture, less disc pressure than slouch posture. So we always hammer that point home. Find the best position, try to find the shut-off valve for pain. Gosh, here we go again. All right. So top causes of back pain. I know Dr. Rodenbush gave the talk probably a month or so or 2 months ago. One of his big takeaways was no smoking. And that's microcirculation and rates of healing. If you have an injury, you don't want to jeopardize your circulation and those sorts of things. The disc derives a lot of its nutrition from movement. So if we're not moving in all patterns, we're losing some of that hydration, some of that nutrition across the membrane. But smoking is a guaranteed way to exacerbate that. So, the other mechanical, so these would be modifiable mostly. We can't modify our genetics, but we can modify how we sit. The frequency of forward bending, there's going to be a little slide coming up that shows how often we forward bend versus how often we backward bend, and it's crazy. Poor body mechanics, excessive sitting. So we try to address all these things with folks and hope that they apply 10%. And usually if they start to apply enough of the right direction and avoidance of the wrong direction, they start to get better. So this is that spinal movement. 2% of the day. We call this extension, and we call this flexion. Okay. Flexion would be kind of fetal position, sleeping, anything where you're bent over. So 94% of our time is spent in flexion, and 2% is spent in extension, and none of that time is spent in full extension. Was that when I was in middle school or elementary school, I was told that these positions are bad. And I don't know why they kind of put that in our heads. For some cases, for some spinal cases, yeah, you're not going to want to do this. Stenosis, arthritis, certain conditions. Others, it's not so bad. So it's really no mystery. We're bending forward 94% of the time. We're spending time slouched. We get to about 50 times at full end range flexion. All right. I put this slide in here not to vilify diagnostic testing. Diagnostic testing is critical in a lot of cases. If you get to physician, if there's some question about red flags or neurological damage, yes, you need to. What we'll find in the clinic a lot of times is patients will come in, with a week or two old back pain, and they'll have it in their mind that they need that MRI in order to proceed, and they need to have the exact cause. Well, this study came out in 2017 in Journal of Spine, which is probably the #1 journal in the world on spine conditions, and it's just reflecting that there's a lot of variation in what you're going to find. If you go looking for issues in the spine, you will find them. We all have them. This was one person, I think she was a 63-year-old female, who went to 10 different centers just as an experiment to see what she would be diagnosed with on the MRI. Across the 10 studies, 49 distinct findings reported relating to the presence of a distinct pathology. So 49 different diagnoses. All right. A lot of them were probably right. You probably have multiple things if you look. The issue is if it's just an acute back pain that's set up, probably 48 of those are irrelevant. They were just incidental. You had that condition. One finding was reported in 9 out of 10. So of the 49, the radiologists, 9 out of the 10 were in agreement that they all had it. So a lot of variety across the board. So the takeaway was, let's definitely educate folks that it is critical and it is essential, but there are a lot of false positive and false negatives as to what's pertaining to the pain. So But again, acute back pain, generally the recommendations of a lot of physician academies are don't jump right into it unless there's some specific criteria to it. The other component is a lot of times if patients have it in their head that they need that coming in, nothing we do is going to apply that. So a patient needs to conquer that fear of movement and have that belief of, hey, we can get somewhere with it. And a lot of times we can't. This is just up in the neck, same thing. Over 1,000, 1,200 asymptomatic subjects. So these patients didn't have any pain, yet you're going to find disc bulging frequently in these guys. So a disc bulge doesn't mean you're in pain, it just means it's an incidental finding. So just know that if you have a film, chances are you'll find it. Whether it's connected to what's driving your pain is the key question. So this is kind of the good news. The body can spontaneously recover from these things. Spontaneous regression or backtracking of the herniated disc tissue can occur, and it can completely resolve after conservative treatment. Sometimes it'll resolve completely on its own without treatment and just with enough time. But if you start implementing the right stuff, ideally you can improve the time frame on recovery. So these would just be demonstrating that the disc doesn't always have to migrate backwards. It can go out to the side, it can go way out to the side. It can even migrate forward. It's a little less common, but those people are typically going to be more sway back, and they're going to have difficulty flexing forward. The people with a herniation going backwards, they're typically going to have a difficult time going backward. So directional preference. We want to try to find in the evaluation by moving the patient around what helps their pain the most, what centralizes it if it's available. And if we can find it, we have them do it a lot. We'll typically tell them every hour. Try to do this. Posture in between is the glue that holds everything together. Imagine you got a cut knuckle, and if you come in and you've been bending that knuckle and you've been stretching that knuckle trying to make it help, make it feel better, it just keeps opening up the cut. You know, a lot of times that's the case. We're just not applying the right stretch. You know, so we got to let that knuckle heal, splint it down, and then start to stretch once the scar tissue is in place. Same analogy for the spine. Now, a lot of times, if they're very acute, we'll start them out, and again, this is a disc bulge that's gone backward. We may have to start them out laying over a pillow, spend 5, 10, 15 minutes, coach the patient early in the morning. They're a little bit more susceptible to back pain, especially a disc injury, because they've laid down so that disc is filled with a little bit of fluid, and then when they first get up, it's like squeezing a more filled water balloon. It's going to be a little bit more susceptible. So just telling the patient, wake up 5 minutes early, lay on your stomach for a few minutes, if that's the right direction for them. Preventative back bends, we tell nurses this all the time. If they're flexing forward all day, you know, try a preventative back bend if it's a pain-free spot for them or if it's a helpful spot. If the patient walks in this way, we probably don't have to do too much interviewing them. We already know what's going on. It's a lateral shift. About 80 to 90% of the time their pain is going to be radiating down the opposite leg. About 10% of the time it'll be down the same. Again, it's just a far herniation to the side or a bulge to the side in most cases. Every once in a while we'll get this from a spontaneous spasm, but more often it's a disc component. These would be just some different things to try to intervene to try to centralize pain. Our end game mission is to make sure all motions get better so that the patient doesn't have to worry about bending forward once or twice once they're done with therapy. We don't want to send them out the door pain-free and then have them just re-aggravate it the next day. Another component following a herniation, we want to make sure that that scarred tissue from the disc doesn't latch onto your nerve, in which case you might have some of those leg symptoms. So once the condition is stable, and if it seems like they're getting some leg symptoms but it's calmed down, we might start them on doing some nerve stretches. One of the tests for recovery function and making sure they're good to go is if they can press up unobstructed, and then they can do a bunch of needed chest stretches to try to reverse that disc migration, and then they do the third set again of the press-ups. If they're pain-free and unobstructed after doing that, they're usually good to go. If they do this and then they have sudden trouble getting back up into full extension, then it's too early. It's not settled yet.
Is there a time frame for each of those pictures? 5 minutes? Or?
It's if we go back, these are typically, so if we're dealing with that very specific disc injury that's gone backwards, we're going to usually go by rate of healing. You know, we want to make sure their symptoms are centralized and pretty well pain-free by the time we're testing them for, you know, go back at it. So we may have them on a certain exercise regimen for, you know, a few days, a few weeks. We might be doing some manual therapy to try to restore that. We normally coach this one for evening hours. Yeah, I definitely don't want you to take away the meaning of today to say that these are exercises everyone should do. But it's like the most common, or one of the most common problems. So you would say, yeah, you're going to want to make sure they're pain-free for a few days, and then test these things and make sure that the scar is stable, basically. So you might do 10 reps, and then another 10 on the third cycle again as a test. So our objectives, really number one is to teach, and I think it's a component that is probably overlooked. We're going to tap into the best resource you guys got, which is your mind. You know, if you understand how the pain is behaving and what worsens it and what improves it, you're going to have the tools to manage it well beyond after you see us. And on that same token, if you go to somebody and they sign you up for 12 weeks of therapy or 12 weeks of, you know, chiropractic, challenge them, because the natural history is that the majority of patients are going to be better in 6 to 8 weeks if you just go about life. So if they're signing you up for a very long thing, or if they're using alignment issues, we all have alignment issues. So I kind of push back on that, and I encourage patients to push back on that, because not every alignment, you see, radiologists think there's 49 different diagnoses in the same person, because the finding is potentially there, but not everyone is related to our symptoms. So push back a little bit that, challenge them, and have them produce some research for you that says, why 12 weeks, why not 6 or so? So it might disrupt the business model of some clinics, but our theory is try to get them healthy fast and try to get them on their own fast, because ultimately, if it works quickly for you and it's as a tool you can use, you don't necessarily need realign. Correct your posture, enhance body mechanics, limit sitting frequency and duration, especially in the beginning. Correct the position, and you will take some of the pressure off. We want to shorten the duration of the problem. So if we could take a 6-week average problem and turn it into a 2-week problem for you, then that's a win. And that's really where we try to apply the results. You know, sometimes we'll take a visit or two to identify, whoop, that was not the right movement for you. If we cause peripheralization, it's still a win because we know what not to do, and we know typically to reverse the direction. Not everyone's going to get better with therapy, but at least try to be able to sort where you should go to next if it's not appropriate for you. You know, what levels, whether it's injection, further testing, consultation with spine specialist. Using that centralization theory and teaching the patients about that. Limit the unnecessary tests. Establish self-management. That's really key. We want you to go and know the next time it comes on, if I'm bending over, gosh, I should probably lie down, and you know, if I feel a twinge, I should probably do X, Y, Z. And you know, sometimes you get that. Sometimes you see patient once, and then you see them again in 3 years for, you know, a check-in. They've had a different sort of an issue that's not responding to their home program. All right. At the tail end, you know, we'll try to invoke strengthening, but a lot of times we're not really seeing folks through that end. We're trying to help them on that way. Ideally, patients are working on strengthening and stabilization so that they control some of the rotation. A lot of times if you strengthen some of those specific muscles that resist rotation, you know, if you're seeing folks over at Premier, you know, a lot of the core stability stuff, there's some good core stability stuff, and there's some things that can put your spine at risk. So I wouldn't necessarily say sit-ups because it's a lot of shear, but instead planks, you know, a little bit less shear, planks, elbows, and knees, once you're feeling pain-free. Problem is, a lot of times if you start this stuff too soon, you take 3 steps back and the patient is in pain again. So if you give it enough time, start smart, start low, and then progressively build. Probably one of the most neglected exercises is just the ability to squat well, you know, getting the knees, getting the hips strong. Questions? Too technical?
You know how you were talking about you were trimming your dog and
Yes.
time to stand up. A person that tends to be a side sleeper,
Okay.
like myself, versus back or tummy, Would you say, based on your knowledge, that it's a good idea to maybe put a pillow between your knees when you sleep to prevent that very thing in
Sure.
the morning when you wake up?
Yeah, we're going to be a big fan of trying to fix the real time fix the alignment. If you find that putting a pillow between your knees helps you wake up a lot easier, less pain, absolutely. If you don't put the pillow between your knees, it's not necessarily a problem if you wake up fine, but it will put a little bit of a sideways tension on your pelvis. Your knee will find the other knee, and some folks are not comfortable that way. The other thing would be look at the firmness of the bed. Some people do great with a real soft bed. Some
Right.
people are terrible with that, and it's depending on their condition.
And would you say walking is the single best thing a person could do for their spine?
In the case of a posterior derangement, on the specific case, yes. In case of someone who has a lot of arthritic change and stenosis, and these are the people you'll recognize. These people that kind of have to lean on the shopping cart. They're kind of looking to open up their frame, and they're not going to love walking. They're gonna like probably prefer cycling or something recumbent, or pool therapy, that sort of thing, where they're a little bit unloaded. But generally, walking, yeah, it's very, very recommended in most cases.
Okay, you talk about excessive sitting. How
Yes.
about excessive standing, where you're standing for 8 to 12 hours a day
Great question.
and have a little side bending on top of it? But when I come home, I just want to bend over and stretch because you've been standing erect for so long.
Great question. So we would probably, in your case, if I'm assuming, we would take the history and we would determine that sitting is probably relieving for you, and you may be dealing with an opposite form of condition. We probably wouldn't take you down the pathway we probably wouldn't label you as a posterior derangement. We'd probably label you more as possibly arthritic category, in which case we may introduce more knee to chest, more abdominal stability, more frequent flexion type exercises to offload that spine. Yeah, if you stand the body's really just not built for any one position for hours and hours on end.
Right.
We like to change
So
position.
when you come home from work, should you stretch out and try to make yourself feel better? Try to stand
Yeah,
better?
absolutely. I would look at anti-fatigue mats. So something underneath, if your employer can.
I did get those. I got those. That's really helpful.
One of the other things we would typically do is if you have a step that you could put, kind of alternate one foot to the other foot, so you change angle a little bit there.
Okay.
Side bending, I would try to eliminate that as much as possible. So if it's a side bend, just take and turn your feet and do that instead. Anything ergonomics or work related, yeah, we want to eliminate twisting and we want to eliminate asymmetrical posture as much as you can. But yeah, you would probably not fall under this picture. You'd probably fall more under. Yeah. Great question, though. Yeah, it just highlights that not every condition is going to fall into the same pattern. All right.
So for those of us who like to lay down, it seems like it was the least stress on your back, on your spine, if you lay down.
For the disc pressures, as measured by those, yeah. But too much of any one thing, this can be the argument that I'm going to lie down because I'm helping my spine. Too much of any one thing is bad. You look at the astronauts, they go up, they have lower exposure to gravity, they grow taller, they have less compression on their spine, but they come back to Earth and they have different issues. So too much of a good thing isn't a good thing in that regard. Good questions. Cool. Thank you, guys.